Hi, everybody. Thank you for joining us for our final UIC Global Health Colloquium of the term. As many of you are aware, the UIC Global Health Colloquium is co-sponsored by the Health Science Colleges. Typically, every year, we dedicate the December session to the observance of World AIDS Day, which takes place on December 1st. So we're a few days late here. This is a day that started in 1988 by the World Health Organization. World AIDS Day brings together people from around the world to raise awareness about HIV/AIDS, to show solidarity with those who are impacted by the condition, as well as to bridge new and effective programs and policies across different sectors around HIV/AIDS. We are very excited today to have with us Dr. Mark Dworkin, who's going to be talking about a mobile phone app that he created called My Personal Health Guide, a talking, teaching, relational avatar that promotes adherence to antiretroviral medications and retention and care. So Dr. Dworkin is a professor and assistant director of the Division of Epidemiology and Biostatistics at the UIC School of Public Health. His current NIH-funded research focuses on technological approaches to improving medication adherence in people living with HIV. He has led research studies on topics related to HIV, syphilis, food safety, and immunization preventable diseases in the United States, India, France, Italy, Switzerland, and Puerto Rico. He's very humble when it comes to his activities and accomplishments, so I'm going to go ahead and expand upon the bio that I was provided. Dr. Dworkin is a board-certified infectious disease physician. He also has a Master of Public Health degree, a Master of Public Health in Tropical Medicine. He trained at the CDC's Epidemic Intelligence Service. He also worked at CDC at headquarters for a number of years in their division of HIV/AIDS. And he also served as the state epidemiologist here in our state of Illinois. Just a side note, he also teaches 2 courses to our graduate students in public health, and they are some of the most well-liked courses at our school. He teaches one on surveillance and another on outbreak investigation. So with that, I am going to turn it over to Dr. Dworkin. Thanks, everybody, for joining. Oh, I will note also, please feel free to submit your questions in the chat. You can also raise your hand and we will unmute you. So thank you.
All right, thanks very much. Thanks for that introduction. I'm going to turn off my video pretty shortly, but as you can see, today's talk is going to be about antiretroviral adherence and a technological approach, in this case, that involves a mobile phone app that's kind of unique in that the phone app incorporates an avatar that talks and teaches. And I'll be introducing the terminology for some people, relational agent, which is what this is intended to do. It's an area of computer science that I learned about in the efforts to develop this. And I've had a lot of help from a number of people on this project over many years, many of whom are acknowledged at the end. I'm just going to stop the video of myself and focus on the presentation. All right, so we're going to talk a little bit about oral antiretroviral therapy and a few key timeline points along the years that I'm just selecting on to make some points. Let me just start by saying in 1983, as many people know, the virus was identified for the first time. I was in college at the time that this happened. And in 1985, I began medical school. There was no treatment for what was then known as human T lymphotropic virus type 3, and also sometimes known as lymphadenopathy associated virus. There were both terminologies, papers being published with either one of these kinds of names at the time before things settled on HIV. And 1986, the virus was renamed HIV. And in 1987, so I'm basically a second-year medical student, AZT is the first drug to be licensed for treatment. It's used as a high dosage medication. We still use AZT sometimes in treatment, but the dosage that's used now is far less than what was used initially. And one of the problems when this medication was administered, particularly in these high doses, was bone marrow suppression, as well as some other toxicities and side effects. But bone marrow suppression, which causes anemia, is especially a problem given that the medication was intended to delay or interrupt AIDS or try to prolong somebody's life. And then you're introducing a side effect that is known to be associated with increased mortality in people. So it really was a double-edged sword. It was the lesser of two evils in the sense that AZT versus nothing, AZT is better. But AZT was certainly not a cure, and certainly was not a panacea for treatment. But it was what there was, and there was a lot of excitement for it at the time. Other drugs followed. DDI was one of them. DDC was another one. Each of these drugs were similar to AZT, but different in little ways. Enough different that people were often sequentially changed when they couldn't tolerate AZT anymore. They'd be switched to DDI or DDC, these drugs emerging. But they had their own side effects as well. And I'm just naming one of them here, painful neuropathy, which we saw relatively frequently. And even today in long-term survivors from that time period that I see in clinic, I will see people who still have neuropathy from early times of their treatment or the virus itself. By 1992, I'm starting infectious disease fellowship. I went to Tulane in New Orleans, and as you might expect, there was a great deal of the HIV epidemic there in the South with a lot of complications and a lot of people basically experiencing what we call the natural history of HIV, despite these treatments being available like AZT, DDI, DDC. But there were a lot of clinical trials going on at the time. And in New Orleans at Tulane, they were participating in the AIDS clinical trials group. And so I was observing passively some of the new drugs being developed and being tested. In 1994, the drug D4T was licensed, also a drug that had the side effect of neuropathy, but it also kind of introduced a new kind of a problem amongst the many problems that drug therapy came with for HIV, and that was lipodystrophy, physical changes in people's face, limbs, buttocks. Uh, Anyone who's listening right now who was treating people at the time would remember this very well. It lasted for many years, this kinds of problems. And so a lot of people didn't want to take their medicines because of these changes. It was, in some ways, it was almost outing them for having HIV and any other stigmatized issues by changing them physically and calling attention to their health. In 1995, the next year, the first protease inhibitor, another class of medication is introduced, sequinavir being the first one licensed. And these protease inhibitors were, there was a great deal of excitement for them because of the efficacy that was being seen and the fact that it was a whole new class, so then you might overcome issues of resistance that had been accumulating from these other kinds of medications. But it came with, a side effect profile, one of which was diarrhea, which was really, really common for some of these protease inhibitors, to the point where patients would tell me about incontinence, not wanting to leave the house because they couldn't get to where they needed to go, even the doctor's office, without having a problem with diarrhea. And so people, both embraced the medications, but also didn't want to take them or wanted to take them selectively. It interfered with adherence to the medication. It's a major problem that accompanied these. Fortunately, however, around this time, what also emerged was the concept of what was known at the time highly active antiretroviral therapy, which essentially is combination antiretroviral therapy. The idea that instead of using these drugs sequentially, that is, we'll try this one, and if that doesn't work anymore, then we'll try this one. Now we say, let's take several different classes of antiviral in this at the same time. And this was modeled on what had been successful with treatment of tuberculosis. And so the idea was multiple drugs with different mechanisms of action. You wouldn't get resistance, and it was highly active against HIV. And it was a revolutionary change. And by 1996, it was getting promoted and adopted very broadly as treatment in the United States and elsewhere. In 1996, I began working at the CDC. I had done my training with the EIS in Washington State, and I worked at the CDC in the division of HIV/AIDS as hospitalization and mortality began to decline from their highest rates. So I was in training while HIV was basically getting worse and worse in terms of numbers, prevalence, and incidence, and and then I was at CDC monitoring surveillance and publishing on surveillance at a time when highly active antiretroviral therapy was kicking in, and we were watching the trends curves steeply decline. It was and the epidemiology of HIV change. So it was really a remarkable time to be involved in HIV epidemiology, particularly surveillance. It would be 10 years before ATRIPLA was licensed. ATRIPLA being a triple dose of antiviral, 3 medications in one pill, with the ability to take just one pill once a day. Another game changer in the simplification of the regimen that could affect and did affect medication taking, making it easier. Because until that time, it was common for people to have to take multiple pills multiple times a day. That was very common, which you can imagine might be a problem for some people. Now, over these years, also another thing that's changed is the language. And some of the language that changes when I was coming up, we talked about patients and about medication compliance, that they were non-compliant. They didn't take their medicines as prescribed. Uh, Eventually, there was concern raised that, this was kind of like a shame and blame kind of language, that this terminology used with patients was not a good idea. And the language of adherence emerged and became much more commonplace, replacing non-compliance in terms of patient care. There's a lot of barriers to adherence of medication. And in the world of HIV, some of these include forgetting, a stigma, side effects, as I talked about, pill burden, low self-efficacy, low health literacy, distance to the pharmacy or clinic, depression, and more. But we're not going to go into everything. The list is actually quite long of the different kinds of things that are barriers to adherence. But it's important to have mentioned some of them now because they informed the research that I'm going to share with you. Now, first of all, why did I focus on young African American men who have sex with men and adherence for this particular research project? Now, the National HIV/AIDS Strategy specifically emphasizes the importance of focusing efforts on groups with the most new infections, and young African American men who have sex with men are such a group. Also, optimal adherence to antiretroviral therapy can reduce morbidity, okay? A personal health benefit that they're less likely to die. I'm sorry, less likely to be hospitalized or become sick. In addition, we've got the benefit of optimal adherence leads to less mortality, less likely to die. Another personal health benefit. Then there's viral resistance. Because these medications have multiple different mechanisms of action going on within the pill, what you're getting with highly active or combination antiretroviral therapy is reduced likelihood that the virus is going to become resistant, which is going to be a personal benefit because then you won't have to change to other medicines that might not be as well tolerated as the one you're taking. But also there's public health benefit because, as they say, treatment as prevention. That is, you're less likely to transmit HIV if your viral load is controlled, untransmittable because you're undetectable. And that leads us to the last bullet, which is the broad transmission. So you're less likely to transmit viral resistant virus if you don't get it, and you're less likely to transmit virus at all if you are optimal adherence. Now, African American men who have sex with men account for the largest proportion of new HIV infections by race, and African American MSM living with HIV have higher mortality, have lower ART adherence, less durable viral suppression, and lower retention in care compared to other MSM. So these are reasons why this particular population was important to study and to try to do some sort of intervention to help them. Now, why did I include an avatar in the intervention that is about promoting adherence? Well, just most people know what an avatar is these days, but it's basically an icon or figure representing a particular person in computer games or internet forums. This is an actual person that we're looking at here who volunteered for being made into an avatar that ended up being used actually at the Science Museum years ago because there was a PhD student here in computer science, and he was working on a project that involved having an avatar as kind of like a museum guide at a particular exhibit. I was touring the computer science department at the time, kind of brainstorming for like, what can I do that would be innovative in terms of research, because it's so important to be innovative if you want to have any chance of getting funding. And I noticed this and I got interested in it. And here you can see the transformation that this particular PhD student did of that person into this particular avatar, which then was further transformed into what looked like an astronaut for that particular exhibit. But we've since used this particular avatar image for the mobile phone app as well. Now, avatars can serve as relational agents, and this is what I want to bring up because it was terminology I wasn't familiar with before I got into this. When we say relational agent, we're saying it's an animated conversational agent designed to establish trust and therapeutic alliance with users over time. You can see in the picture here, you've got a patient in the hospital, and then you've got something as simple as a kind of cartoon character, but that's teaching and talking to the patient. This can be, for some people, less intimidating than an actual human being, that they may have biases about how they experience the social interaction. It could be more accessible to patients that have a wide range of computer or reading or health literacy skills. And it may establish what I said before, a therapeutic alliance with patients through verbal and nonverbal behaviors such as empathy, attentiveness, even social dialogue, and humor can be written into the script that is spoken. And the speaking could be synthetic, like some sort of robotic language. We've all heard that sometimes. Or it could be recorded dialogue, which allows for an actual person to essentially be like an actor and to introduce more emotion, which can be important when you're trying to impart empathy. That's how I used it in the mobile phone app. that we'll be talking about is recorded dialogue, where I coached someone to speak a certain way. Avatars have been used to promote or change behavior. You can find evidence in the literature where there's been a program for modeling weight loss behaviors. There was hospital discharge instructions. That's where that photograph was from on the previous slide. Post-traumatic stress disorder, addictions, body image disturbance, binge eating disorder. And I came across one study of condom use for MSM, promoting condom use. So there have been a variety of papers out there of the use of this. Not a lot of randomized clinical trials, though, very little. Application, okay, so then, when you do something like this, a behavioral intervention, you're expected to have some sort of model that you're basing it off of. In this case, I chose a relatively straightforward model, the information, motivation, behavioral skills model. And in this case, for example, in terms of information, the avatar can explain not to wait the next day to take a dose when you miss the dose in the morning. It can impart motivation, like by encouraging medication taking on time. It could convey behavioral skills, like the avatar might explain how you can use a weekly pill box and how that could be helpful. And then the behavior that we're interested in is that medication doses are taken, and the outcome measure in our case is at least 80% of the medication is taken by pill count or self-report or whatever the measure is for the study. Here you can see my personal health guide. That is our app. You can see our avatar and a particular background. This happens to be what we call the let me explain function. There's a scroll bar of like 28 questions, and the avatar will speak the question when it's clicked on and then go ahead and answer it, sometimes with animation as it's explaining things. Nice thing about it is if somebody's mind wanders, if somebody's a substance user, if somebody's distracted, it can be replayed. If somebody has low literacy, it can be replayed over and over again as they try to learn it. And they don't feel any shame that they might have felt if they were in a doctor's office and something was being explained, they didn't understand it, and somebody doesn't want to ask the doctor, can you explain that again, or admit that they don't understand. So again, this is a theory-informed mobile phone app that's promoting ART adherence, viral suppression, and retention in care, developed for, in this case, young Black men who have sex with men living with HIV. But ultimately, this kind of concept and platform can be used much broader than this. We have a customizable, realistic, relational agent, the avatar, with plain speaking human voice that emphasizes, motivates, and relates to, empathizes, motivates, and relates to the user. It was informed by 5 iterative focus groups in Chicago with young Black MSM living with HIV. And that was an NIH study. Both this and the trial that I'll be presenting are from NIH funded studies. Now, the focus groups, again, there were 5 of them. And when we began, we had this like storyboard, these cards. We would show that to the men around a table, and we would get their thoughts. Okay, here's what we're up to. What do you think of this? What do you think of how it looks? What do you think of how we're talking about it? And so on. And so this gives you an idea of what they were shown. And then, right away, it was like, I like this. And then a whole bunch of them agreed. Somebody volunteered. Say I'm afraid to get some help. You would know how to tap into this app, and people think we are trying to play games. This is genius idea. Thank you. And I was like, oh, wow. They are not just giving me affirmation here. They're enthusiastic for this, product that we're creating. So that really made me feel good. And then they also gave me negative feedback, which I needed. They disliked the medication icon that was going to be on the phone. They said, in case someone is looking over your shoulder, No one who is HIV positive wants anything on their phone that screams out HIV positive, or even anything about their health. They wanted it to not look anything like about their health. And so ultimately, we ended up creating an icon for the phone that doesn't look anything like it's for your health. It's actually looks as like the most boring app anybody would have that nobody would want to tap on. It's called Battery Health, and it looks like it's maybe something about the battery health of your phone. Here's some more quotes from these meetings. The avatar should ask, what do I do if I feel too down to take my medications? And somebody volunteered, have the avatar tell them to take a walk in the park. And we built that kind of messaging in where the avatar addresses depression and the avatar has constructive ideas for what someone might do. A lot of times your physician says, oh, you're fine. But you haven't had a chance to say, but this here hurts. This is what's going on with me. And so one of the things we built into the app was a side effect tracker where you could record your side effects so that when you go to see the doctor or healthcare provider, you could show them, look, this is what's going on. You got your notes, you've got your dates, you've got frequencies of things happening there. And it's much more informative to provide that to the provider than just how you doing, and then somebody even forgets to bring it up because it's a rushed appointment, as we know occurs sometimes. It could tell you it's time to go see your provider, and I was like, oh yeah, we don't just have to have medication reminders; we could have appointment reminders, and so we built that in as a function. What would be nice? They're trying to be nosy, and he can change into a game image. Only we know that he's a puzzle now. So then I was like, okay, yeah, stigma is a big deal for this population. While they're using the app, we built in a function where basically they could tap suddenly on the screen and it would disguise the screen into thinking like somebody's doing something else. Because there's a lot of people who were telling us that people getting in their quote unquote business was a real problem for them with their phones. I wouldn't want it to pop up saying, take your meds. I'd rather just have the alarm. So that was important too. Again, the stigma was a big deal to these folks, and we paid attention to that in a variety of ways. They also gave us feedback on negative images that we had included, like in teaching about like what is AIDS, what can happen to you if you don't take your medicine. I had these images here on the right, which showed the avatar on a ventilator and looking kind of miserable in a wheelchair. The idea was, let's keep it real. And initially, I didn't get like the negative feedback, but then in like later focus groups, which with different people, by the way, I got some seriously negative feedback about this, and I was like, oh, I got to be careful not to do stuff that really turns people off anywhere in this app. It said, take that visualization off immediately. Once you put the visualization up there, everything else didn't matter. Don't nobody want to see that image, somebody else said. That hurt to see that, somebody told me. So I got rid of these negative images. I was like, okay, I was well intended, but this is the whole point of the focus groups is like to help me not go too far with anything and to keep it where it's going to have acceptability in the population. Because if they basically delete the app, despite everything else good that's going on in that app, I've lost the battle right away. So we did a pilot study to look at preliminary efficacy in young African American MSM living with HIV, 3-month follow-up after download of the app. There was no control group for this study, and we looked at pre and post pill count. There were 43 enrolled, and 26 were available for the 3-month follow-up in pill count. And what we found with pill count adherence was that greater than 80% reaching that optimal of taking at least 80% of your medicine improved from 62% at baseline to 88% at follow-up. It was statistically significant. So it was like, hooray, this thing looks like it could do some good. All right, so my personal health guide, what's in this app? Okay, the avatar asks and answers questions with branching logic. So it has that interactivity where depending on how you respond on the screen to something the avatar might ask you, there'll be a different response. There are recordings of motivational messages from healthcare personnel and community peers who are living with HIV. In other words, sometimes when you log into the app, the avatar will greet you by saying, "Do you want to hear what a friend of mine says?" And then if you say, "Yeah," then you might hear a doctor or a nurse or a mental health care provider or somebody, a young man, African American man living with HIV, who has something to say about their personal story and about taking medication and sticking with it and so on. And there's more than a dozen of those in the app. So each time you would say, "Yeah, I'll hear what a friend says," you get something else. And so they're about 90 seconds to 2.5 minutes. There's let me explain questions that I showed you with the scroll bar. There's ability to set reminders for medication taking or for appointments or for blood draws. There's viral load and CD4 count graphs to monitor trends. Now, this app is not connected in any way to the medical record, the electronic medical record. It's an independent app that can be deleted and everything's gone for privacy purposes. It would also be difficult, but not impossible, to connect it to multiple different medical record systems. So that would create a whole new level of complexity to this, which I'm not against, but it's easier to have it where you go to an appointment, they tell you your viral load and CD4 count, or you get it through a portal and you enter it yourself. But then you can look at trends over time and you can see things are good or things are bad, things are improving, things are not. Show My Medicine is a function that can educate them about HIV medicine so they can both enter their own medicines. So they go to the ER. Sometimes these folks go to the ER, they have different problems. They're asked, "What medication are you taking?" And it's like, some of these names are really weird and hard to remember. And they've changed over the years for these people. So they don't know what the medicines are, and sometimes they mispronounce them, and sometimes they can't remember them at all. Here, basically, they're in the app. You can show the doctor and say, "These are my medicines." But also you can tap on them, and it'll explain about the medicines to them, which they appreciate. And also they could be curious, like, what about other medicines? And they can click on those and learn a little bit about them too. All right, how am I doing taking my medicines? This is another function where you can be asked on a daily basis, did you take your medicine today? And if you say no, then it'll ask why. And so it's recording all this data, which can be shown in calendar and also can be shown as a pie chart of reasons for not taking medicine for those doses missed. So this could be very helpful when you're going to the doctor and they're asking you which is standardized on the medical record that I'm filling out when I see patients. It says, to ask them, in the last 2 weeks, how many doses did you miss? And that's about it for talking about adherence unless you do anything more. But this provides more granular data that a healthcare provider can look at and make decisions about. It's like, I notice you're a weekend misser from this data you've shown with me. Let's talk about that. So you can have a more informed discussion based on actual information if a patient is inclined to enter it. Like I said before, there's a number of privacy features like pausing the avatar or hiding the screen. You can customize the app and the avatar with certain music and appearance. Obviously, a lot of young men find that enjoyable. And we've also gamified it. So there's this dating game where the avatar has a choice of 3 dates, and the host is asking them a question, one of these educational questions that's being taught in the let me explain function. And, two of them answer it wrong, one of them answers it right. And you have to guess which one of them answered it right. And if you guess wrong and pick the wrong date, then you are transported back to the let me explain question, which just kicks in and starts teaching the correct answer to that particular question. On the other hand, if you answer it right, you get praised, and sometimes something is unlocked within the app that makes it a little bit fun and interactive that way. Here's some images, screenshots from the avatar. You can see how he could be customized to be kind of cool and professional, or this next one, here he is in front of a pharmacy, and he's kind of like a healthcare provider. Um, we offered a female, kind of nurse-like looking alternative too, if they wanted to, and they've got all this female voice dialogue as well. Here you can see the customization over here on the far right top. There's more customization than this, but you can change his glasses, sunglasses. He's got earrings, stethoscope, pens, hats, and there's a number of things that can be done that people liked it. Somebody referred to him after the trial as their little buddy. They loved playing around with their little buddy. And then there was music, and some of which unlocks as a prize, and other stuff is just baked in there as background music that's playing during certain functions. The app progress will be displayed periodically, and you can see how so far this one has been used about 50% of all the stuff that's out there. In other words, there's spontaneous stuff that's going to be available. And the more you use it, the more new things show up. And so that's meant to encourage repeated use. And so this gives you a sense of like, oh, there's still a lot more stuff that I could be finding or hearing that I haven't encountered yet. So yeah, I'll return to the app. That's the idea anyways. This next image here is an example of animation that might occur while the avatar is explaining things. Because again, we're dealing with some people with low literacy, and it's particularly helpful for them to have visual learning. And then the medicine manager, this is that particular thing where there's a number of things like show my medicine, you can enter your medicine, how am I doing taking my medicines, the viral load and CD4 count trackers, the record my side effects, you can make notes for the upcoming appointment. You can even record a motivational message. And so with this thing, essentially what we're doing is saying, hey, and the avatar tells them this, hey, one of the things you can do in this app is you can record yourself, or you could record somebody that, you care about, like your mother, sister, and they can say something motivational to you, and then I will offer it to you in the future spontaneously. So once it's in, and you can do it with more than one person if you want to, but then there'll be a time where you enter the app, and then spontaneously the avatar will say, hey, would you like to hear the motivational message? And they click on it, and then, oh yeah, 2 months ago I recorded my mother who was telling you, baby, stay with it. I know you can do this, or whatever. And, that might have an effect on someone's behavior. So we offer it to them as an option. All right, so we got funded to do the randomized controlled trial to test the efficacy of my personal health guide. I'm going to focus on the adherence aspect of that in terms of the outcome. A couple of analyses. I'm going to show you, mainly I'm going to show you the first one, to determine the efficacy on ART adherence at 1 month post-randomization. So looking at short-term efficacy, the 6-month efficacy, we have that. I'm going to show that to you very briefly, because we're still working on writing up that paper, and it's preliminary, but we'll get to it. We hypothesized that those randomized to receive my personal health guide would have greater ART adherence compared to controls at both 1 month and certainly at the 6-month follow-up. So study design, randomized controlled trial, recruiting throughout the United States. We didn't plan that originally. We planned for a 3-center study, University of Illinois at Chicago, and also Core Center, Emory University, and the University of Mississippi Medical Center. We launched the study in February 2020. I think you know what happened in March of 2020. The lockdown begins, and COVID. And so it completely messed up our study and all of our plans. And we had to pivot to basically become a mostly remote study, uh, as opposed to an in-person kind of a study. And as a result, there was a lot of learning curve involved. It changed some of the dynamics of the study. In some ways, it was a good thing. In some ways, it was a really disruptive thing, knocked us off of our timeline immediately upon starting the project. And I know that some people who are listening now experience the same thing with studies that they might have been participating in at the time. Eligibility requirements were 18 to 34 years old at recruitment, self-reported as Black or African American, male sex at birth, and male gender. Self-reported having at least one male sexual partner in their lifetime. English speaking, had to own a smartphone. Initiating or already prescribed art, and either self-reported non-optimal adherence in the last 30 days, self-reported having a detectable viral load in the past 4 weeks, or were referred by a healthcare professional as having non-optimal adherence. And study participants completed questionnaires on a wide range of items. We administered the questionnaires to them, including questions like sociodemographics, depression, screening, substance use, and art adherence. All right, so in this study, there were 315 participants who completed the baseline questionnaire, which was provided to them 1 month before the app randomization. I'm not going to get into everything because there's a lot more going on with this study, but and I'm running out of time. I want to make sure I get to some of the results. 253 participants were randomized, 1-to-1, to download either My Personal Health Guide intervention app or an attention control app that was designed to deliver food safety education. Okay, so everybody got an app. Everybody got an avatar platform for this app. It was a matter of what was it teaching about. And as you can see, 315 became 253. So we were having problems with loss to follow-up early on, as we're launching this thing throughout the COVID pandemic. Plus, this is a population that has a lot of challenges in their life, and is so retention is an issue here. Participants were followed for 6 months with monthly check-in calls. And art adherence for the past 30 days was assessed at baseline and monthly using the Wilson's 3-item self-reported measure. All right, 1-month analysis. Short-term efficacy was determined by analyzing the effect of My Personal Health Guide at 1 month post-randomization among those who responded to the first monthly check-in call. And logistic regression using backward selection was used to evaluate the efficacy and adjusted for baseline adherence. I'm not going to go into, because of time, very much of the baseline demographics of the population. Let me just point out a few things. Most of the enrollment was performed by UIC or Emory, but people were recruited from many states as we targeted a variety of areas of the country with higher HIV incidence. Ultimately, we had I think 24 or 23 or 24 states people residing in. Almost 80% participated remotely, and about 7% of these men also identified as Hispanic. A lot of the HIV incidence in Black men is in the South, and we had high representation of participants in our study from the South, 52 to 62% of the men, depending on which arm of the study that you're talking about. There was diversity in terms of education and literacy as well. I'm just going to forward through these because we can't get into it too much due to time. But about a fourth of the men had at least moderate depression, and most reported moderate or high social support. All right. We looked at what was each man's art adherence at baseline with current medication available in the US, taking at least 80% of each month's pills commonly achieves the desired goal of very low viral load or undetectable viral load. I'm just going to move forward here. All right, so here what we see is that visually the slice of the pie with non-optimal adherence in our My Personal Health Guide app pie gets much smaller after 1 month. Okay, and there is also a decrease in the pie slice with the food app, but it's not as big of a decline. So that's visually seeing that there appears to be some efficacy to this app. Now, when we worked with our biostatistician, Dr. Lee Liu, and Ruichi, a biostat student, help us with the analysis, we found that participants randomized to the My Personal Health Guide had nearly 4 times greater odds of optimal adherence at 1 month post-randomization compared to the attention control group. I was thrilled, and not just to see that, the app looks like it's working despite basically the study having one arm tied behind its back with everything that was going on, but the fact that the magnitude of the statistic is so high and statistically significant. So evidence of short-term efficacy, we've got that. Now, the 6-month follow-up analysis, as I said, we're still working on writing this up. We had a variety of issues with the loss to follow-up along the way. But the bottom line with the 6-month follow-up is that participants randomized to My Personal Health Guide had 1.5 times greater odds of optimal adherence over 6 months compared to the attention control group. So even out to 6 months, we're able to show some efficacy. So I'm not concluding here, but as far as this particular study goes, short-term efficacy, this RCT is the first to demonstrate short-term adherence efficacy of a relational agent approach to improving medication adherence. It provides evidence that this line of research is worth investing in further, refining the app to enhance efficacy and try in other populations, I think is where future research can go. As far as 6-month efficacy, this RCT also demonstrated evidence of longer-term efficacy, further supporting it as a promising area for adherence intervention. And as far as study limitations, self-reported ART adherence can overestimate individual medication taking behavior and therefore may introduce recall and social desirability bias. App use was voluntary, resulting in high variability in app experience throughout follow-up, unlike a medication that's administered to people or observed to be taken or anything like that. We're dealing with a different kind of situation here, yet we still were able to deliver some really great results. And of course, we had lost to follow-up issues as another study limitation. But study strengths include the RCT has a diverse sample, including a large proportion experiencing housing insecurity, moderate to severe depression, and variability in health literacy and education, all issues that can interfere with adherence. Overrepresentation of young Black MSM living in the South was a strength, since treatment adherence is a form of HIV transmission prevention. And so studying this among men in a high HIV incidence region and finding efficacy supports its use there. Okay, now I see that it's 10 minutes to 1, and I have a few more things I want to show, but I'm just going to gloss over them so that there's some time for questions. So as far as additional analysis, we also looked at usefulness and acceptability. Okay, and we found that the app had high usefulness and acceptability. You can see, for example, would you recommend the app to a friend who is living with HIV? 92.9, 93% of those with the intervention app said yes. It's nice to see that even the control app was recommendable, 80%. So this idea of relational agents is kind of encouraging. To what extent did the app make you feel in control of your health? you can see we have relatively high response on a 1 to 10 scale there. Avatar asked if you took your medicine today, how do you rank that in terms of usefulness? And, the median score was 10. In fact, the median score was 10 for most of the functions that the app provided, and it was high for all the rest. We looked at the change in HIV-related health literacy 6 months after download. We found a small but significant improvement in HIV-related literacy, basically a selected number of questions that we had taught about. The food control app also was liked. Most participants ranked the app favorably. 65% said the app affected their behavior in a positive way. And food safety knowledge increased significantly in the food app arm as opposed to the adherence arm. We've even translated this literally and figuratively into a global health setting, working with colleagues in India to do a study with seed funding. And, here is Suma, who's
హాయ్
talking
నేను
here.
సుమ నేను మీ ఆరోగ్య మార్గదర్శిని నేర్చుకోవడానికి సురక్షితమై హాయ్
Yep, thanks, Suma. Okay, anyways, preliminary data from the 94 people we've already interviewed shows most participants in Hyderabad responded the app would be very useful. You can see there 77, 10 out of 10 responses to that particular question. And we've also asked them a number of other questions, such as, what do you think of this function? What do you think of that function? We demo a demo app that uses Suma, which we created there. Okay, I'm going to go ahead and stop sharing slides. Well, maybe I don't know if I'm supposed to stop sharing slides, but I'll go ahead and take questions at this point.
Hi, Mark. Thank you so much for your tremendous presentation. It's so exciting to hear in greater detail about your work. So I really appreciate you taking the time to share this with all of us today. So we do have a few minutes for questions, and there are some questions in the chat. Again, please feel free to submit your questions either in the chat or the Q&A function. So the first question we had was basically about the IT skills required to build out this platform. I don't know why I'm losing it now. It says, what platform was used to build this, and what level of IS/IT/coding skills are required to build this type of application?
Yeah, so that's a question that I can't answer, but I can connect somebody to our computer scientist, Dr. James Lee, Sangyun Lee. He works at Connecticut College, and I'd be happy to provide you with his email if you just email me for it, and you can get more detailed clarification. In many ways, what I do is I sort of write all the script, I design everything that we want for the app, and then I tell him, and then he asks me questions, and we work together, and he does all the programming.
Great. Another question, were the participants provided incentives for participating in the study?
Yeah, we did have incentives. In fact, we even had to increase them along the way because we were struggling with the retention over time, and they varied, from like $25 to $50, and then by the end of the study, to try to ensure that we had people and had 6-month follow-up, we were even increasing, I think, to $100 near the end of the study for the people who were late in the study.
Good. Did you feel that longer term usage of the app would keep the ART adherence the same as the beginning, or did the gains in adherence, I just lost it. Or, oh no, let's see, where is this? Or did the gains in adherence over time? I'm sorry, you might be even able to see it. It's having a hard time navigating for me.
I think I understand the question, though.
Okay, sorry. Good.
I hope I do. We were able to see adherence from month to month over time, and it varied, and the people who participated from month to month to some extent was varying as well. Somebody might be willing to you return our call, so to speak, and month 2 and 3, but maybe vanish in month 4 or 5, and then they come back for month 6. But with that said, we saw, high efficacy at month 1, and we saw quite high efficacy at month 4 as well, but not as high in the other months. But so it did vary, as you might expect, anyways, for any individual. But that was what we saw. What we want, ideally, is to refine the app and try to figure out, how can we make it so that it's even higher and more engagement and so on.
And another person kind of just commented on that, with declining adherence levels, what does this say about the long-term efficacy of the app?
Right, right. And what it
Long-term
says
use of
is
the app, excuse me.
what's that?
Long-term use of the app, excuse me.
Oh, right, right. And first of all, it's not clear to me whether or not this or most of the app, is intended to be, used long term or not. Because some of it is engaging people so they understand the rationale for adherence better than they did before. That could lead to a change in behavior because now somebody understands things differently. On the other hand, there are aspects of the app like reminder functions and so on that might be good and important to be using continuously over time. But you don't necessarily have to play these let me explain functions more than once, if you're paying attention to them to have gotten what you want to out of them. So it's kind of complex. I'm not sure what's the ideal situation. It probably varies from person to person as well, what would be best for them. And so, yeah, I mean, there's a lot we don't understand with this.
The next question, thank you, Dr. Dworkin. This is a very interesting approach. HIV infection and medication has been linked to the development of pulmonary arterial hypertension, a life-threatening and often silently progressive disease. It would be nice to know and track symptoms of secondary HIV-associated conditions using the app. Are you thinking of including additional features? Additional features to the app?
I'm definitely thinking of including additional features to the app. In fact, that's part of what a benefit of this trial was to interview folks at 6 months and ask them questions about the different functions and other things that they would want. And then there's also just knowledge of how the world of HIV and prevention is evolving. And so I currently recently submitted a grant that is like, let's take this to the next level and let's also refine the app. And for example, STD prevention is what we're proposing, one of the things that we're proposing to build into the refined app going forward.
A lot of people are expressing their kudos and gratitude for giving such an exciting presentation today. We had another question about if there has been any consideration of using this in PEPFAR. If you've had any connections.
I haven't. I would be thrilled. As far as I'm concerned, like, oh, look, this thing could work. And then it's like, how do we get this thing out there? It could translate into a whole bunch of languages. It's not super complicated. It is difficult to make this, into anything you want it to be, but it's not so complicated to like turn it into an app in India, for example. So then it's like, okay, well, we could do that in other languages as well and change the avatar, keep it simple, maybe even, and just hit on some of the most fundamentally useful things. And then, if there's investment, then certainly more could be done. But even without a lot of investment, I don't think it would be that hard to adapt it.
And so in these final minutes, I'm wondering, and this is the Global Health Colloquium, if you could just comment at where you are in your adapting this to work in India and what the next steps are there.
Yeah, so thanks to some previous funding, including students getting funding through the Doug Pissarro Travel Scholarship, Global Horizon Scholarship, and also some seed funding. We've got our partner that we work with, Share India in Hyderabad, and they've been out at multiple NGOs. I've been over there a couple of times in the last 2 years on site visits, and they've been doing interviews of people living with HIV, particularly men who have sex with men and women, especially, but not only, female sex workers. and showing them the app and interviewing them, and we're determining acceptability and feasibility. 94 people have been interviewed so far. Our study got shut down due to some administrative issues with the government because we had some grand idea of asking some people in a different state to participate in the study too. And then all of a sudden it led to some administrative stuff. So we're waiting on reapproval to get restarted. But even just the 94 is probably sufficient to make the point, which is that these folks are telling us they like it. They're interested in it. They would like to see us progress. I have a grant that I'm writing right now to try to get Fogarty funding to basically do a proper acceptability and feasibility study and to do a pilot over there with a control group. Not sure how well that'll go, but at least we'll give it a try.
Great. We do have another question. Great presentation, Mark. Thank you. Do you have thoughts on how the app could include or interface with generative AI?
Yeah, I asked our computer scientist, like, are we doing AI? And he said, yeah, we're doing a type of AI. But as far as generative AI goes, yeah, that is something that we could integrate. It's something I would like to do, but basically we haven't had the ability to do. We're working in these micro steps of, trying to get funding just to begin the next thing, which is even more fundamental than doing, incorporating generative AI. But that's something I would like to see is to take some of the pressure off of the avatar, because that requires recorded dialogue, and have him possibly have a buddy or a partner who does the generative AI. And so then people can reach into the app and explore things far beyond what we have created in our branching dialogue.
All right. Are there any final questions for Dr. Dworkin? Okay, I think that's all we have. Well, again, thank you very much for sharing your time with us. Everybody, thank you for joining us today. Please join us next term. We'll have a couple of global health colloquiums. They are on the first Wednesday of the month. So we look forward to seeing you again, and I hope everybody has a restful holiday break. So thank you.